Thanks everyone for joining us tonight. I'll now pass over to Bruna to start the meeting for us.
Good evening. I'm Bruna Barbosa, Education Coordinator with PHN. Welcome to tonight's Western New South Wales COVID-19 GP's update meeting, GP's Guide to Care of COVID-19 Positive Patients in Western New South Wales. I would like to start tonight's meeting by acknowledging the people of the Waijuru Nation and the different nations on which each of our participants meet tonight. We are committed to working in the spirit of partnership and collaboration with our region's Aboriginal communities and peoples to improve their health, emotional and social well-being. I warmly welcome Aboriginal and Torres Strait Islander Australians who are presented tonight. Before we start the meeting, we'll do some housekeeping. So please mute if you are not speaking. To ask a question or do a comment, please, you can raise your hand via the toolbar, or you can pop questions into the chat box direct to everyone. Today's meeting will be facilitated by Dr. Ai-Vee. She is GP with Dubbo Family Doctors, and she is involved in the provision of shared care for COVID-19 patients at recent residential aged care facilities outbreaks in Dubbo. And our panelists will be Dr. Mel Berry and Nerida Powell. Our agenda for tonight. So the first part of our meeting will be talking about care of low and medium risk patients at home, followed by a Q&A session with Dr. Ai-Vee and Dr. Melberry. And in the second part, we'll be talking about care of residential aged care facilities case, followed by a Q&A session with Dr. Ai-Vee and Nerida Powell. Thank you, Dr. Ai-Vee, for facilitating this meeting tonight, and you can start sharing your slides now. Thank you.
Thank you, Bruna. How's that looking? Is that behaving itself?
Good.
Is it? And try again. Might be good to start at the beginning instead of the end. Okay, so we'll kickstart. We've got a fairly full session this evening, but I hope it gives everyone a really good chance to understand where things are at with COVID care for patients who are low and medium risk, but also our COVID positive patients that inevitably will turn out in more of our nursing homes as time goes on. So we'll kickstart today with looking at endemic COVID and some predictions about case numbers. We'll talk through COVID positive patients at home and have a Q&A session around that following. Then we'll talk through the COVID positive cases in aged cares and a Q&A session after that as well. So keep starting with endemic COVID. So what are the expectations? I'm privileged to be part of the New South Wales Health COVID Clinical Council meetings each week. And these were the figures that were presented to our Clinical Council yesterday. So if you look at this rather busy table, but effectively, these are some of the countries that New South Wales Health have been monitoring in the fact that they have had reasonably high vaccination rates and that they've been lifting restrictions at various levels. But it gives us some ideas to what our numbers might look like in the not too distant future. You can see in that first line there that New South Wales is listed on the 18th of October as having a population that's fully vaccinated of 65.6%. And that's different to the vaccination numbers that are quoted to us in Australia, and that's because these figures are taking into account the whole population, children included, whereas the figures we hear about in the media locally are quoting the figures of people who are 16 and over who are fully vaccinated. So you can see we're fairly equivalent to where Israel is at. We're much better than where United States is at, and they certainly have opened up much earlier. But you can also see there the impact then on the numbers of cases plus the numbers in hospital and numbers in ICU. So where New South Wales would like to head towards is to be looking at those numbers that are at least at Canada rate and Denmark rate with fully vaccinated figures, because that looks nice and secure then in terms of admissions to hospital and admissions to ICU. But just wanting to highlight that irrespective of the ability of our acute hospital system to cope with admissions in ICU, there's this very important column as well, which is the number of cases that are appearing in the community. So in New South Wales, we're looking at 43 cases per million over that period. And you can see in the UK, huge numbers compared to our rates in New South Wales. And they have fully lifted their restrictions. And that's at about the vaccination rates that we're at the moment. So fortunately, we're not going to be in that ballpark figure, but probably we're looking at somewhere double our existing case numbers at the moment, and perhaps up to triple that amount. Intensive care admissions, you can see, are still looking pretty good though. When you look at New South Wales, but those countries, again, we're keeping our eye particularly on Denmark and Canada. They're keeping nice and low. So meaning to say that we may well have fairly big numbers of cases overall, but the actual percentage of those then that end up in hospital and ICU, the expectation is that remains low in a highly vaccinated population, and that makes sense. This is a very hard to see slide, I acknowledge, but I'll just go through it. But basically it compares New South Wales, Canada and the UK. And you can see, we had a little wave. We thought that was big enough, but certainly the wave that we've had recently has been much bigger in size. Canada has really had the 4 waves, and the UK has had quite a varying journey through the pandemic. I just wanted to point out that these first dose and second dose vaccination rates, so there are the blue and the red lines you can see, and that makes sense that then, despite these case numbers that are up, you get this purple line on the graphs on the right-hand side, which is the mortality rate. And you can see in New South Wales, we've managed to keep that pretty low, despite the case numbers that have been quite high. And the expectation certainly is, with the high vaccination rates and increasing vaccination rates, that we're continuing to have that mortality rate will remain low. Just going to highlight Singapore as an example as well. They've got a population of 6 million. New South Wales has a population of over 8 million. And they're very well vaccinated in Singapore. The second dose, 84%, plus they're working through booster doses fairly recently too. But you can see that in the community, this is new cases in yesterday, and that looks pretty shocking, doesn't it? 3,000. But the vast majority of these people have no symptoms at all, very mild symptoms, and stay well. So moving on from that, we'll talk through care of COVID positive patients at home. And I guess looking at those case numbers overseas, there's a recognition that in Australia, in New South Wales, and in Western New South Wales, we are fairly likely to get very high numbers. And at a Ministry of Health level, there's an absolute recognition that will mean that the capacity of the hospital virtual care teams to be able to cope with looking after those huge numbers will be exceeded. But there's also been the recognition, particularly in the last few months with the outbreak in New South Wales, also absolutely been the recognition that it's fairly clear that you can risk stratify patients into low risk, medium risk, high risk and very high risk, and that in fact the low and medium risk patients can be very appropriately cared for by general practice, and meaning to say then leaving our hospital system able to cope with the high and very high risk patients, but also all the other usual hospital care that has been parked to a great degree, elective surgery, usual care of patients. There's the intention to be able to return to that, and so a lot of the staffing that has gone to virtual care teams right across New South Wales, and also to vaccinations, those staff members will need to be returning to the usual roles as well. I'd just like to invite Mel now to jump in and give us her experience of what's been happening with COVID care in the community. Mel has been amazing in pulling together a whole team, a whole multidisciplinary team of people to look after COVID patients in the community. And I think, Mel, you pulled it all together in about 4 days, didn't you? Just because you had to.
Yeah. Thanks, Ai-Vee. That's absolutely true. I thought I'd just present our first 1,000 patients just to give you a bit of context of what has happened so far, and just commenting on what we've just seen. And thanks so much for presenting those graphs, because I think they're really important. So there's a few things with when you look at the UK and the US, and it's that when the UK and US opened, they opened with removing all precautions, including, for example, in the UK, there aren't the necessity to use masks. So if we take away all of our precautions, then our numbers are going to increase significantly. So I'm just going to quickly take you through the journey of how we've ended up with the COVID care and the community team. So essentially, we had our first outbreak started on the 14th of August, and we had 11 patients. Half of those were paediatrics. And I work as a clinical governance director and an emergency physician, and there was a bit of serendipity involved in this because I'd been dealing with a patient who was COVID positive a few weeks prior to this, and sort of had realised that possibly the plan from the district of running and managing COVID positive patients with our existing hospital in the home services was not going to work with huge numbers. And one of my very good friends was working in Sydney Virtual, which was an already existing COVID care community program. And I contacted her and I said, tell me what you're doing. So when we got these first few patients, I was approached to see if I could stand up this program. And the first thing we did is we said we need to know about these patients on the day that they go positive with their swab and that the public health unit knows about them. So we are informed on the day of their swab going positive, and those patients instantly go into our intake team, which is run by a nursing-led team who uses a templating model, and they go through and re-stratify patients into more, initially, because they were wildly unvaccinated, moderate, high or very high risk. And from that initial risk assessment, they then are moved onto a review team, and the review team, depending on how risky the patient is, so if they've got lots of comorbidities, we may review them twice a day. They would get a medical review early on, and we'd be watching them very closely to see when they may need to go into hospital. Unfortunately, a lot of our patients early on had a lot of other complexities, not only medical comorbidities, but socially there was food security issues, there was mental health, drug and alcohol issues. And so what we did is we wrapped around services so that were providing care to these patients so that they could stay at home. About 58% of our patients were Indigenous in the first few thousand patients we've seen. and each Indigenous family is assigned to an Indigenous support officer, and that has been absolutely integral to our work, and that has been amazing. The other thing that we have is we have on the ground support, including drug and alcohol and mental health and social work, and also associations and affiliations with justice, and also with community services. So hopefully the patient transports through the 14 days of their illness and comes out to the end where they're discharged. And the discharge process to de-isolate a person from COVID is quite complex. And so we've learned how to do that, and we've taught our team how to do that. We have pivoted. All of our services were within existing services, and we just changed the roles of people. So we had a remote monitoring service that was for chronic care patients. We then made it for COVID patients. We had an existing virtual GP service. We pivoted that, and then we called on a lot of our friends who were GPs in the community, and we said, can you come and help us? We're in a disaster. And I am so grateful to them because they basically came and worked with us. We had acute physicians such as myself, a paediatrician, general physicians or hospital physicians who came on board. There was CNSs and CNCs across the district who were working in the acute space. They came and they wrote a lot of the protocols. So it's an integrated model between chronic care, acute care, and it's been made into this new virtual hospital, and it did happen over 4 days, which is actually incredible. Could you just go to the next slide, please? I just wanted to show you a little bit of our demographic data because I think it's quite powerful. So it's a 50-50% split between male and female. These are the first 1,000 patients we saw. 58% of those patients were Indigenous, 40% non-Indigenous. Most of these patients are seen by a nursing-led review. So most of these patients, 70% of them are seen purely by nurses. However, 300 or so, or nearly 300 of those patients had been seen by doctors during their journey. Now, of those 277 patients, 99 of those were referred into hospital, and 66% of those were admitted to hospital. And of those 66%, about 30% went into ICU and ventilated. There were some patients that self-referred to the hospital, and the deaths have actually changed since this slide was made. There's actually been 13 deaths in total. Now, of interest, a number of the deaths have actually been patients who've never been swabbed, and so have just presented very late into EDs, almost when things are too late. So our two main roles in the COVID care in the community is, one, find the sick patients, and two, support people so that they feel comfortable to stay at home with their illness, knowing that they're being looked after as well as they can. And when we recognise that they cannot manage at home, then we bring them into hospital. I'll just get to the next slide. So we've got the lowest admission to hospital rate across the state. So it's sitting about 6%. And I think there's a few reasons for that. So we actually had, if you look at the first 1,000 patients, it's quite a young demographic. And I would say to you that children don't get sick with COVID, and that has been the experience of the Sydney Children's Hospital Network as well as our own. We've seen over 700 children. One child has needed intensive care for actually significant respiratory symptoms from a COVID. 3 children have needed to come in to be seen for diarrhea and vomiting, and the rest have been managed at home. Next slide, please. So this is the demographic of patients that were actually admitted into hospital. So you can see that predominantly they're unvaccinated. So 77% of these patients were unvaccinated and 14% were with one vaccination. So only 9% had both vaccinations. And you can see it's still quite a young cohort, and there's a slight predominance for female to male being admitted to hospital. Just go to the next slide, please. You can see in the early on of the pandemic, there is a spread of patients, but certainly Dubbo wore most of the initial outbreak, and then many of the hospitals that were draining into Dubbo. Next slide, please. And the big thing that's different about us, as you guys know, is that we are not metro. We are not a few kilometres for an LHD. We're the size of a small country. And so that has never been done before with a remote service in terms of how do you manage an outbreak across a very diverse space. And that was something we really needed to work. How were we going to do that? Because one solution that might work for Dubbo in terms of calling patients doesn't work in Burke. And so we had to pivot and change and mould our service to work better in different places. So this slide's about why patients need to come in hospital to be reviewed in ED. And as you can see, dehydration is actually really common and a reason to need to come into hospital, and shortness of breath, obviously. And then there's some other reasons that all are fairly reasonable things that you would send patients into hospital. The other thing that we always say is that you're sending in patients to hospital for review, and they may not need to be admitted, but they still need to be seen in person by a doctor. And if we can't do that, by donning the PPE and going to see someone at the bedside at their house, then they're going to need to go into hospital. Next slide, please. So this was an analysis. We presented this at the Rural and Remote Community of Practice, and this was actually an initial analysis prior to the 1,000 patients, just looking at what the transport issues were. So obviously there are not unlimited resources. And so we did have a lot of initial analysis to see like what the transport issues were, and it mostly was the fact that there's a tyranny of distance. Next slide, please. The issues that we tried to overcome is we spoke daily to the state retrieval consultant, and they actually moved an asset into Western LHD to deal with the increase of patients that were coming from the smaller sites. So this is an important slide to talk about. So this is what day of illness patients need to come into hospital, and this is our data. This is our data about our patients in Western New South Wales. So you can see there's a predominance of patients needing to come in around about day 4, day 5. That's when they get sick. The other time you will see them coming in is about day 12. So they have these 2 spikes, but definitely between 5 and 7, that's usually when they need to come in and they need to get more support. As you can see, 72% of those patients come to the ward, and then the rest gets to go to ICU, or there's a small percentage that go back home. Next slide, please. In terms of admission and how long people stay in hospital, you can see that there's a group of people that need to come in. There's a lot of diarrhea and vomiting associated with Delta COVID. So you see there's a couple of spikes. So patients do need to come in, they get rehydrated, they go home. But looking at that, you see that there's a number of patients that actually stay in the hospital for more than 3 weeks. Now, I think that's really important, because if an outbreak gets out of hand, then you can imagine if you've got a number of patients that are coming in and taking up a bed for longer than 3 weeks, eventually your hospital resources are going to become clogged. And particularly in our service, as you know, like the base hospitals have less resources than what we have in a metro service. There's not another huge base hospital that you can just pivot to and move patients to. The other important thing is that we thought that you would need many more comorbidities as a risk of needing to be hospitalised, but there were people that were unvaccinated that didn't have, like either had 15% had no comorbidities, and then just under 15% had one comorbidity, and that might be obesity, it might be asthma, and not like asthma, I've been in ICU asthma, just a bit of asthma, and they still ended up needing hospitalisation. Next slide, please. Look, I might actually stop presenting because I just wanted to give you a bit of an idea of what the issues were just with that demographic data. So these are some of the cases which just identify some of the issues, but I think the real issue here, or the real thing I really wanted to talk about, is how to manage Delta and how it is possible to manage it in the community. So I might stop presenting now, and then we can move on to some questions and also move through the other presenters.
Thanks, Mel. What I might do is take the GP perspective with COVID care in the community, and then we'll open up to questions to the wider group. I'll just go back to sharing. Okay, so as Mel has just shown us, the CCIC team, so COVID care in the community team with Western LHD, has been undertaking this process of looking after all of the COVID positive patients to date, the risk stratification process, monitoring and reviewing them, and then at day 14 plus discharging them or de-isolating them from care. So that's that model of care that's been there. Now, in the endemic COVID situation that we're moving towards at this point in time, the CCIC team will still absolutely be critical, and its role will be focused on the high and very high risk patients. But absolutely in Western New South Wales and in fact statewide, general practice will be critical to looking after low risk and medium risk patients. And so this is a proposed model of care moving forward, and we've got the ambitious aim to get this all up and ready to go by 1st of November. Hence tonight being the starting point for discussion, but we'll also plan to have further opportunities for questions and answers, and getting everybody feeling confident with providing care for COVID positive patients in the community. So low and medium risk patients, next step is to just confirm that they have got that level of risk, that it is in fact low and medium. I'll talk you through how we risk stratify people. The monitoring and review process will involve the PHN having a process whereby they can send the medium risk patients, pulse oximeters, together with an instruction package in order to allow the patient themselves to do some self-monitoring, and ideally that's 3 times a day. But from the clinical review perspective from our GP teams, it will need to vary from patient to patient, but the consideration might be, say, every 3 days for somebody who's lower risk, and perhaps daily for somebody who's of a medium risk level. In other regions, there's certainly not touching base. The plan is not for GPs not to have to touch base quite so frequently for the patients, but I think this is a fairly safe frequency of visit to begin with. Important, I mean, the whole monitoring and review process is about identifying, like Mel's slide showed us, you know, it's at day 4, day 5, up to day 10, 12, peak if they are going to have clinical deterioration, that's going to happen at that time, and that's when we want to make sure that we can pick that up and escalate the risk and transfer care as appropriate. And then to go on to do the 14-day de-isolation if they tick all the boxes. And again, we'll talk through that as well. So, you know, COVID's an infection. We've heard a lot about it in the media. We've read a lot about it in all our GP news, GP and articles and journals. And I guess to date, there hasn't been a lot of involvement from GPs in the direct care of COVID positive patients. But it is an infection. You know, we look after lots of infections. We're used to looking after lots of different infections. But what's special about COVID? And it drills down to 3 different things. One is that now we know that there are particular risk factors that we can actually determine the level of risk. Secondly, that this very important thing about monitoring for clinical deterioration. So I guess in most other infections we deal with, they tend to be worse early on in presentation. With COVID and particularly with Delta, we're looking at a few days where possibly they look quite well. There might be sudden deterioration for the higher risk patients in particular. And then, of course, the important thing about trying to prevent transmission of that COVID infection to others. There's some resources which we'll share after this session, but which are really useful to have a quick read through. And there's a couple of ACI documents, the Agency for Clinical Innovation documents, released in New South Wales. These have both been updated fairly recently. Talks about caring for adults and caring for children in the community. There's a national flow chart which is helpful to give an overview of management of adults with mild COVID. And there's the HealthPathways New South Wales collaboration resource, which I am privy to, but which I have utilised to then put together the health pathway for Western New South Wales. So first we'll just talk through determining level of risk. How do we know if a COVID positive patient is low risk and medium risk as opposed to the high and very high risk? amongst all of this, everything I'm going to say in this next little while is actually going to be housed in HealthPathways, so you don't have to be furiously writing things down. Within the next 24, 48 hours, it should be live up on the HealthPathways. If you haven't already looked into HealthPathways, there's the link and username and password. Katie will share these slides after the preso today as well, so you can grab that username and password. But yeah, talking through determining level of risk. So there's basically 4 different things that help determine level of risk. Vaccination status is 1, age is the 2nd, medical risk factors and social risk factors also play a part, and then you've got the clinical features that the patient's presenting with the COVID infection. I won't read through all of these things, but you can see basically if they've got immunosuppression, if they've got significant chronic disease, but also I'm going to just make a special point of these things that's lower down in the list, but really important. Pregnant women are absolutely at a higher risk of serious disease. Those who are obese, sorry, that should be a 30, not a 30 years old. And if they're frail or have disability due to other things that may not be listed in this medical risk factor list, that also imparts increased risk for that patient. Social risk factors, and you know, the demographic that has been affected first up in so many regions, and especially Western and Far West New South Wales, the demographic that certainly had lots of these social risk factors, and how that will look as COVID becomes endemic. The prediction is that you know, we'll see COVID a lot more in our populations who may not have these social risk factors behind them, but that we still need to provide the care for. So I talked about current clinical features as one of the things that predict risk, and you can stratify people with mild clinical features, moderate or severe features. And mild's pretty easy, and I think we'd easily recognise when somebody's got moderate or severe features. But basically anybody with moderate or severe features, they need to be under the care of the CCIC team and not under our care. But if somebody's just got a low-grade temp, if they've got a bit of a cough but nothing too drastic, they're not breathless, they may have some mild GI symptoms, but they've got a good hydration level. These are the sort of people that fit into our care. So putting all those things together, basically the low-risk people are the fully vaccinated, so that's the people who are eligible to be vaccinated at this point in time, fully vaccinated where the second dose has been more than 2 weeks ago, the age between 12 months and 50 years of age. So the people under 12 months old, the babies under 12 months of age, automatically go into the high and very high risk group to be cared for by the CCIC team. These low risk people have none of those medical or social risk factors, and they're asymptomatic, only got very mild clinical features. We move up to the next category. There's two groups of people there. There's the fully vaxxed people. They're older, but they don't have any of the other risk factors. And over here, we've got unvaccinated or partially vaccinated in that young age group, but no other risk factors. And so you can see that all the other ones that might be of more concern, under 12 months old, at least one or medical or social risk factor, if they've got moderate or severe clinical features, they should be under the care of the CCIC team. So monitoring for clinical deterioration, let's just have a look through that. So the low-risk people, based on that risk stratification we've just talked about, they don't need oximetry, and that's been decided at the ACI level, but also has played out in real life in virtual care of patients to date, in that they just tend to do well, and oximetry is not actually required. But asking the patients to monitor their symptoms and to do that 3 times a day, but also to have a think about things like, how are they going in terms of accessing food, how are they going in terms of general well-being. This is something that the PHN are actively working on at the moment as part of the patient instruction package that will be made available in the very near future to give patients guidance about how to self-monitor. It'll also be uploaded into HealthPathways too, so that when you do have that COVID positive patient who's low risk, you can actually give them that package that gives them instructions about how to check their own symptoms and signs 3 times a day. The recommendation is that they be teed up with a friend or a family member of theirs who can give them a phone check a couple of times a day. And that's part of, that it permits us not to have to be ringing them every single day or twice a day if we're confident that they've got that support person who can do those checks on them and also help out with escalating care if things do develop. For these low-risk people, at the moment, clinical review is appropriate. And the suggestion is around every 3 days. You might increase it, you might decrease it, depending on what other supports are around that person or how confident you feel in that person's ability to reach out for help if required. And, all the things that you normally know about your own patients as to how well they do access care if needed. And so those clinical reviews will be looking at the red flags, have they got COVID signs and symptoms, and that you can suggest symptomatic management for, care of pre-existing conditions, and diabetes and BSL control is probably the thing that stands out the most. Checking that they're doing okay with home isolation. Recommendation is certainly if they've can manage to have their own room with an attached bathroom, that's the ideal, and to try and limit the spread. Certainly saw one family who, a young boy in the family had caught COVID at school quite miraculously. The rest of the family didn't get infected at all, and he was quite happy because he stayed in his room the entire 14 days playing his video games, and the family were able to keep safe. And then checking on their general well-being. It's no fun being isolated, and so anything that can be put into place to support the emotional well-being as well as the physical well-being during this period. The CCIC team is absolutely available to provide support, and Mel and her colleague consultants are there to be able to give medical advice as required. But there's also the whole the team surrounding Mel and consultants who may be able to give additional help and advice in relation to all the non-medical aspects of COVID care as well. Now, in the medium risk group, fairly similar, and the only difference being there is that they'll score a pulse oximeter. The PHN are rapidly standing up systems that will allow us to request for them to organise a pulse oximeter to be sent out to these medium risk patients. Sonia Berryman is heading that at the moment, and written into HealthPathways will be a contact number that we can call and organise for the pulse oximeters to be sent out, together with the instruction package on how to use it, and some advice around COVID care too. For those who are high and very high risk patients, hopefully the process that we're working on will mean that these patients don't come to us. However, if we do notice that it may well be our low or medium risk patients develops moderate or severe clinical features, then that will trigger a prompt referral to the CCIC team, and they can take over care. So in terms of monitoring for clinical deterioration, what are we actually looking out for? None of this is rocket science. In terms of signs, it's those odds that would normally worry us anyway. And here's some specific numbers, I guess, that have been put out by the ACI. So persistent tachycardia greater than 120, no tachypneic, SATs under 95%, or those who normally have a low SAT rate anyway, that's 3% lower than the baseline. But one important thing to actually check on as well is, somebody might be fine sitting there with a normal saturation, but you get them to get up and about, walk around the room and see what the SATs are doing. There may be quite a drop there. And fever lasting 5 days, and this is more so in the children's pathway. Mel, did you have any comments about those signs?
Just that they have been investigated, and there's a study that will be coming out looking at the first 800 patients Sydney Metro, showing that there's a correlation between the SATs below 95 and actual need for hospitalisation. And so the things that we do about hypoxia is the two things, is exertional SATs, so you can get them to walk on the spot for 30 seconds if there's someone who'd be able to do that usually. And the other thing is that there is this, you would have heard earlier about it, but they're happy hypoxic. So that is definitely a thing. So there'll be people who don't realise that they are hypoxic, but they are profoundly hypoxic. So it is believe the SATs monitor. If the SATs monitor is saying 75, it is probably 75. And don't be tripped up by it not working because it probably is. And they don't look like that classic COPD patient who's very air hungry. So that's just a thing. And the only other thing I would say is that there is a subsection of patients who get myopericarditis, and that's probably what's happened with those patients that have suddenly arrested at home. They're probably not purely respiratory, but actually myopericarditis, and that's something that is prevalent in Delta. And the other thing is chest pain. So there is a lot of chest pain with Delta COVID. So it's just important to sort of investigate what sort of chest pain. So they can get pleuritic chest pain, which, be suggestive of pericarditis, but then most patients get this cough, and they describe it as the chest pain of trying to sort of suppress a cough. And I think, of the 1,000 patients we've seen, that's certainly been really prevalent, and the cough is pretty horrendous. Hemoptysis is pretty common as well with these group. And headaches with kids.
Thanks, Mel. Okay, on to preventing forward transmission. So just a few things to highlight in terms of home isolation. Obviously, at the beginning of your touch base with patients, educating them about the importance of isolating at home, but also within the home in the context of who else might be in the household. Talk through practical support. Do they need assistance with food delivery and medications? Do they have family and friends that can organise for that to occur? And then general well-being. Video phone consultations are absolutely preferred. It should be a very, very rare situation that you need to go and see them face to face. And so, think carefully about transmission to yourself and staff as well. If needing to escalate care to hospital, obviously if they're critically unwell, 000, but do make sure you inform the ambulance service, but also the emergency department that this patient's COVID positive, so they can make sure that they're geared up properly. If they're not critically unwell, the recommendation is to call through to the CCIC team. They've got all of the networks set up and knowing who to send where and how to facilitate that so that there's not an obstruction to transfer of care. Any other comments around that one, Mel?
No, that's what I would say too. Yeah, all good.
And then care of household members. So I think everyone's aware that the risk of Delta transmitting to someone else in the household is very, very high. So being able to touch base and check as to what all the other household members are, how they're doing, and if there are people then who in the household who then subsequently test positive for COVID, there needs to be a pathway to care for them as well. If it happens to be that you're their GP as well, as a lot of other families do see us in the whole family group, then that works well. If there's somebody within the household, and we were just talking about this earlier today with the CCIC team, if there is somebody in the household, however, who ends up being a higher risk patient, may well be that the CCIC team will need to look after the whole household together, given that one person who's at a higher risk of clinical deterioration. So I'll just open up now to questions from the group.
Ian Spencer here. We've experienced a couple of situations which I think are worth mentioning. First of all, we've actually had a home death, and that was really caused by social disconnection and a reluctance to call for help. And that was in the methadone clinic clientele, drug and alcohol people. So I think that they probably fit into a at-risk group themselves. So that's one point that I'd like to make. The other point, we probably had about 5 households which were all COVID positive. And because we run quite a complex at-risk antenatal clinic, which is a Wellington clinic, not just a surgery clinic, we have quite a number of Aboriginal girls that come to the antenatal clinic. And so a number of them have been caught in households where they were COVID positive, and they were quite well, but they were obviously needing to be seen from an antenatal point of view. And the discussion that we had was whether we would go to the house with all the PPI and do the obstetric consultation, which had its limitation because they might even need a quick screening ultrasound or something like that. So the other option that we had questioned was whether they could come to our fever clinic and be seen in an obstetric capacity, and then the room was completely washed down and so on. They're just my 2 comments.
Yeah, so I would agree with you, Ian, that a vast majority, unfortunately, of our patients in the first wave that we've seen most recently have been quite disadvantaged, and a great deal of our patients have been either drug dependent or previously drug dependent, or had an alcohol issue and a concomitant mental health issue, and yeah, that's been a real challenge, and some of the things that we've put into play is actually having mental health and drug and alcohol support officers attending at the scene rather than doing anything in that space remotely. And then in terms of the maternity space, we have used a midwife service within our service. So all pregnant women above the age of 12, above the gestation of 12 weeks are seen by one of our midwives. And all pregnant women we assess as being high risk because of our experience in the metro, where unfortunately there have been a number of deaths, or not deaths, but gravely unwell women. And unfortunately, there's been 2 caesarean sections performed in EDs where women have then been crashed onto ECMO. So we've been very mindful of pregnancy as being a risk factor. We have had one patient who had a fetal death in utero, but she was quite not unwell with COVID when she had the fetal death in utero. So to our knowledge, we're not sure whether that is related or not. There has been some data that suggests that there is a relationship between COVID and fetal death in utero, but genuinely the patient is very unwell when that occurs. The other thing we have been doing is giving sotrovimab, which is a monoclonal antibody, and given that has been given to pregnant women in Sydney, women that are unvaccinated that are pregnant and they're in the first 5 days of their illness, we are offering them the sotrovimab infusion, which is an infusion that is given over an hour, and then they're kept in for 3 hours of observation, and we're finding that is very well tolerated. And anecdotally, we are seeing that people that have sotrovimab who are very high risk, are tending to not need to be hospitalised. And that's another part of our service that we offer.
Thank you.
Now, with the sotrovimab, initially that was available in only very limited quantities. Is it still fairly limited in its availability at the moment?
No, so my understanding that there's a far greater supply, and we have certainly been prioritised as a district to receive it, because there's an advantage for people who are remote to receive a medication that might improve their outcome and reduce their need for transport to a big site such as a Sydney site or a base hospital.
Fantastic.
There are some issues with it though. It's done on one trial. It was 200 patients and 200 patients with placebo. So I give a very frank view of this to the patients. I say this is done on a trial basis, and I think, you know, if we weren't in this time, we wouldn't be offering it as freely. So I'm very frank with patients. And the other thing is, when we set up how to determine who gets sotrovimab, we've set it up with some respiratory specialists, intensive care ID specialists across the district, and an ethicist as well, because initially it was a small amount of the drug that we were given. We wanted to be very clear that we had been as fair as we could be, offering it to the people that we thought were going to get the most benefit. And then also, if something hadn't gone right, we really wanted to be clear that we'd really been very vigorous in our decision on who would be offered that drug, because it has caused me some unease. I mean, you get unease from giving a vaccine that's been given to, 1 billion people across the world. This is a drug that was done, and there was one trial, and then they've rolled it out widely.
Thanks, Mel. Alex, you've got a question.
Look, I'm from Mudgee with my Moore, who's on tonight. With the state opening up in a few weeks' time, just a few comments. The GPs in Mudgee are very keen to be involved in the care of low-risk patients. We've got an LGA of somewhere in the order of 24,000 people, which certainly isn't as big as Orange and Dubbo, but certainly half their size. And we're very keen to have a hands-on approach to that. Should we be fostering greater ties with our local COVID in the care team, or the hospital team? I know who's involved locally. Should we be setting that up now with the state opening up in a matter of a week or two? Is the question. Should we be driving that very quickly and get those use those protocols that you've already got to put in place? Secondly, I look at that risk, the risk factors, and a lot of our patients have diabetes, a lot of our patients are obese, and a lot of them do have risk factors, which immediately puts them in the high risk group. Will that remain that way? Should we look at re-stratifying risk now that we've got people that are vaccinated in the community? I'm not talking about immunocompromised and people who are clearly going to crash regardless. But, if we do have an outbreak in the elderly, which is quite possible in our community, do we re-look at those risk factors? Will there be enough oximeters for everyone? There's some of the questions that are going through my mind.
So I think the thing that I've learned in this outbreak is that there's a solution for now and a solution for later. So I call it like the Bandaid solution. So you start with a plan, and then it's like a living document, Alex. So I never say this is what we're going to do forever. So you're absolutely right. At the moment, I would say we're going to keep us, this group in the high risk. And that's because we don't quite know yet. So we know what we know from the UK. We know what we know from, Singapore, but they're all a bit different to us. So I think we could probably compare ourselves best to Canada. They have a more similar sort of healthcare system, and they have a diverse, there is a rural component as well. But in terms of should we re-stratify and move people differently dependent on vaccination. At the moment, what the state is saying is this is the new risk stratification is they've actually said everyone under the age of 65 with no comorbidities goes to a low medium group and the rest goes to the high if they've got comorbidities. My lived experience has been mostly unvaccinated, but we have seen vaccinated patients, and certainly like in the outbreak that's going to be spoken about in the RACs, they're predominantly vaccinated and they still got unwell, but because of frailty probably and because of their existing comorbidities. So I think what we should do is start with this and get everyone used to it. And then if we really have an outbreak, we will have to rapidly change and we will have to rapidly move this way and that. But I think the best thing to do is get as many people keen to be wanting to work in this space because it's a little bit different to usual business. And so if we can get as many people interested in taking patients on as, who are their normal patients, but just, it's the only thing different about COVID is that it's highly infectious. That's the different thing. And it's a slightly different disease, but, after 5 COVID patients, you've got it, but it's the highly infectious nature of it. And it's all new, right? How long is this vaccination going to last? Do we need the boosters now? It's all like changing very quickly. Even the public health laws, they change weekly. So my answer to that is I think we should start with this model. And then when we're all got comfortable in a week or two and everyone's like, you know what, I'm really good with this, then I think we change it again. And I'm very happy to mold our model, but I just want to get everyone comfortable first. And I think, yes, if Mudgee wants to come and work now, let's just do as much as we can now, because I think we're in the eye of the storm. From the modelling I've seen, like I'm hopeful because at the moment we've got a trickle of patients coming through. And everything sort of has been opened, but we don't have Sydney travel at the moment to the regions, but everything is sort of open. I'm like, it doesn't feel like it should be as big as it is. So either what's happening is people aren't getting tested, which is probably what's going on, or they're so vaccinated that they're not sick, which is, great. I hope this stays.
What we have noticed on the ground, and certainly with the respiratory clinic, is that within 2 weeks of opening, our numbers have tripled. And my concern is that once there is Sydney travel, amongst those we'll be seeing COVID fairly quickly. And I hope I'm wrong, but our respiratory numbers have increased, and it's predominantly children from childcare and school, and I suspect because they're all back together. And so, I guess we want to know what we need to do to move forward as a town, apart from attending this meeting tonight. What do we need to do in terms of establishing links with our team, and what do we need to do with the PHN to move forward? Because as I agree with you, this is the eye of the storm, and we can all see it coming. Whether it's weeks away or longer, that'd be a miracle if it was longer, but there'll certainly be a surge in winter, without doubt.
Alex, if I can make a comment on that, in terms of further preparation, it would be, I think, getting the team knowing how to log into HealthPathways and letting them know that HealthPathways will change frequently, as the model of care might need to be tweaked as things go on. And Mel and her team and myself with HealthPathways and the PHN certainly catching up on a very regular basis at the moment, and I envisage that will continue for quite some time yet, until we get things smoothed out with the model of care as we see numbers come into the region. The other piece of work that the PHN are doing, apart from getting these oximeters together and the instruction packages together, there's some work being progressed in terms of getting a monitoring platform that patients will be able to enter in the symptoms and signs that then show up and link in with GP software, and that's called Care Monitor. And there will be more around Care Monitor when we've got that set up and ready to go. So watch this space. But that will mean that there's easy visibility of how people are progressing at home, without necessarily having to touch base with them really frequently and asking them those questions, because they'll be entering that into an app for those who are capable of doing so. So there's that behind the scenes work going on at the moment. What else can be done at the practice? I think, if you've got people aware of the elements of care with COVID, and that everyone feels comfortable enough, or at least knows how to reach out if they are needing assistance with looking after a COVID positive patient. I think a lot of this is, GPs haven't been involved in looking after COVID positive patients. There's a little bit of fear out there amongst certain GP groups about what it might look like, based on what they've heard about in the media, I guess, for the most part.
So are we expecting a package soon that will sort of give us some guidelines as to what happens when we do get a patient, when we'll be notified, and clarify our role? Is that what you're saying, Ai-Vee?
Yeah, that's right. And if I can just share my screen, I'll show you what the draft is looking like. This is hopefully going to be finalised over the next 48 hours or so. But let me see which one of my multiple screens. So this is what HealthPathways Live Western New South Wales site looks like. COVID-19 information is there, that's been there to date. I'll just highlight this one, which is shared care. So patients who are currently COVID positive are looked after by the CCIC team, but we've certainly had plenty of patients reach out to the usual GPs anyway. And so this one currently provides guidance about what to do with those patients there. However, what's in the pipeline at the moment, and it's still in draft, you won't be able to see this in the live pathway yet, but sometime in the next 48 hours you should be able to. And this is the guidance here. So when you get that first positive notification, some dot points there as to what to do. At the first telehealth consultation with the patient, steps people through finding out basic information, but that double checking that the risk factors, determining the patient's level of risk. In HealthPathways, if you haven't looked at it before, anything that's in blue, you click and there's a drop box that will appear. Yeah, and then it talks us through as well subsequent consultations and the clinical reviews that you do every few days or each day, depending on the level of risk, what to do during those consultations, but also the 14-day de-isolation, what are the criteria for that, that's included in that. So once this is uploaded, and I'll send a message out, and it will appear on the PHN newsletter, but I can get the team the PHN team to perhaps send an individualised email to GPs as well, just to make sure that you're aware that that's all there to be utilised. We had a question. Does that answer things okay, Alex?
It certainly does. Thank you very much.
Terrific. Okay, and there's just a couple of questions there, and just highlighted, and Mel's answered on the chat. But Mel, did you want to speak to that to the whole group as well about chest pain in COVID positive patients?
Yeah, look, I think the thing is it's sort of about the type of chest pain, isn't it? So, again, it's about level of comfort. So if you're very convinced it's like this, people are they have a cough, and then at the end of the cough, they feel like it's a little bit of chest pain and it's associated with muscles, then no, I wouldn't send that into the ED. But I'm an ED physician, so my level of comfort will be fine about that. But then if it's pleuritic chest pain, if you're worried about ischemia, then you send the patient in. There's no question. The thing is, you're going to see a lot of kids get chest pain. And there's a good guideline that is available from the Children's Hospital with COVID positive patients that we will definitely distribute. So that's all about managing COVID positive kids in the community, and there's plenty of kids that are getting that sort of coughing chest pain. And again, I think it's just a level of comfort. If we sent every patient in with chest pain that has COVID, like that would be a lot of patients.
And I guess, Mel,
so it's just again about
the thing that's possible for people to do is especially, yeah, especially when we're kickstarting and unsure, there is that there's absolutely the opportunity to call the CCIC consultant number for advice as to, you know, do I sit on this patient, or in fact do I need to send them in? So that would be preferable to you know, rather than directly sending the patient into hospital when possibly they could be okay at home. Okay, were there any other questions, or else we can move on to our discussion about aged care facilities?
I think Ian has a question.
Oh, Ian, you might be, you're on mute. Ian, can I get you to unmute yourself?
I'm right now? Yeah.
Yes.
We've been doing vaccinations, and we've done over 2,000 vaccinations. WAX has done the same, but maybe this question could best be answered by Sonia. Is there a shortfall in the Pfizer vaccine that's coming to Wellington? Because I'm hoping there's somebody here from WAX and they can answer for themselves rather than me ask the question. But they're not vaccinating after a certain date, which will not include the second Pfizer vaccine. And in that situation, the people that are wanting the second Pfizer vaccine, where will they get it, and how did they get it? Thrift Street itself is going to continue vaccinating AZ and Pfizer until we feel that everybody's had a second dose, but maybe this is a problem that is occurring elsewhere.
Thanks, Ian. There's no shortage of vaccine anywhere across our region at the moment. In fact, most practices have excess doses that they're trying to get rid of. What I'll do tomorrow is I'll have a chat to WAX and see what's happening, and I'll let you know.
Okay.
Thanks, Ian. Thanks, Sonia. Okay, we might proceed on with the next part of our talk, which will be focused in on the care of COVID-positive patients in aged care facilities.
Ai-Vee, I'm just gonna I'm gonna have to leave, but I just wanted to say I'm very happy for anyone to give me a call anytime, whenever. I always pick my phone up unless I'm on the floor in the ED, in which case I'll get back to you. But look, thank you for having me tonight, and I'm very happy to take any questions at all, ever.
Thank you so very much, Mel. Really appreciated. Okay, aged care facilities. So this is just to share the experience with the aged care facility outbreak in 2 of our racks in Dubbo. And I guess, you know, with the thought process that likely at some point in time we're going to see COVID coming through quite a few of our facilities in a not too distant future. There were certainly good learnings from participating in care, and I think we had a fairly unique model in Dubbo with this, because in the metro regions, all of the aged care facility outbreaks excluded GPs fully, tended to involve geriatricians working at the local health districts, and a team of people, but not the usual GPs. And so in Dubbo, we ended up, just as Mel described, that we did some rapid cycle change and would constantly reviewed how things were going, but we did end up involving those COVID positive patients' usual GPs together with the aged care nursing staff bearing in mind that quite a few of the nurses normally working there were furloughed to begin with. Some refused to come into work because they were just scared. And some of them actually were not permitted to come into work because their spouses wouldn't let them. But there were a whole lot of agency nurses who were brought in to assist with care. And some, one in particular who came to one of the facilities who was just absolute gem to work with. She came from Melbourne, but this was, I think, her 7th aged care facility outbreak she'd helped out in. And so that was a great, really helpful to have that past experience. We had the CCIC nurses also meeting daily with GP and aged care nursing staff, and really easy access to the CCIC consultants whenever we needed further advice. It did mean that all our GPs who committed to caring for those patients also made a commitment to have the mobile phones available 24/7. What we did find out though was, in fact, it was business as usual for the most part, in that there were very, very few phone calls that happened in the after hours period. The bulk of it happened during the daytime. And Nerida Powell, as our community palliative care nurse in Dubbo, was tremendous in assisting for those patients who did require then end-of-life care as well. So I think all up, if memory serves me correct, we had 28 cases across the 2 facilities. The bulk of the monitoring for clinical deterioration happened at the aged care facility nurse level, and supported by the CCIC nurses. So fairly similar to, I guess, how we normally look after the patients, in that the nurse contacts us if there's a concern and they need to escalate care. There's absolutely a care of pre-existing conditions that needed to occur as well, for some patients more than others. What was really good to see was the whole system support that really came into play, and that was at a regional level, but also at a state level and a Commonwealth level. And so there were meetings happening in the background every day about organising infection control, about organising staffing. So what happened very, very quickly in the first instance was both facilities set up what were called red zones and amber zones. And so the people who were COVID positive were housed in the red zone of the aged care facilities. And it did mean some shuffling around of rooms, but amazingly that made such a huge difference in terms of stopping the spread. So there were cases sort of diagnosed sort of in the first week or so, but beyond that there was no further spread of COVID to the other parts of the both facilities. Having said those positive things, the best laid plans, well, gosh, I think every aged care facility in Western New South Wales has been taken through infection control, extra visits from the LHD supporting them, having sort of outbreak management plans come into set up, documented. What happened at our 2 aged care facilities? Well, one of the more senior nurses said, "Oh gosh, we looked at that and went, none of that applies anymore at the moment." And so it was a matter of troubleshooting everything that came out, finding a solution for it. And amongst those things that came up from a GP perspective, the communication was really difficult to begin with until we found solutions for that. The immediate response of the aged care facilities was to divert the phones to a centralised Sydney number, and so then it ended up being GPs trying to get in contact with the nurses, being quite a long drawn out process in trying to get back to the red zone nurse. And so, you know, the troubleshooting we did around that was these red zone nurses and also the amber zone nurses had a special mobile phone number that we could tap directly into. So things like that, which were, you know, I think it's hard to dream these things up, but the important thing being to keep problem solving day by day and keeping the communication going amongst all of the players in looking after the patients. Medication charts and prescriptions were really, really challenging. Both these facilities did not have online medication systems. And so basic things like the fax machine lived in one part of the facility, which the red zone nurse could not access. And so, again, we had to come up with Bandaid solutions for these things. And in fact, you know, much as the college would probably cringe, we did end up doing a lot of emailing and photos of charts and whatnot to make sure that people were getting the new medications that they required. The pharmacies were great. They, you know, the fact that we could give them image prescriptions that they could then deliver to the aged care facilities. A few other things there, but I won't go on about the best laid plans. But clinically, the things that stood out was that it was really important to just double check with each patient and their family and significant, you know, the spokespeople for them as to the goals of care. And so there were around just under a quarter of the residents who did go to heaven as a result of this COVID outbreak that happened. But much of that was related to the fact that these people had decided that, you know, look, if they came down with a pneumonia, or if they came down with sepsis for other reasons, or they came down with something else, that they did not want to be transferred to hospital and for comfort measures. And so really important that the discussions repeated again in the with COVID in mind. And it required sort of, I guess, a rapid learning curve for us as GPs looking after these patients to be able to say to families and the patients, look, if you go to a hospital, this is what they said they can and can't do. And so, in fact, what we learnt pretty rapidly was that, look, if somebody's got a normal oxygenation level, then they're not candidates for dexamethasone, and in fact would make things worse. But if they are requiring oxygenation, then dexamethasone is absolutely an option. And, you know, the support from the CCIC consultants in helping us make those decisions. Dehydration risk actually became a thing. A lot of these people did lose their taste and their smell, and just didn't want to eat. And also, you know, we add in a bit of dementia and add a bit of this and that other comorbidity, and the dehydration risk was absolutely there. We got around it a couple of times with subcut fluids. That required a fair bit of negotiation with the aged care facility management to permit subcut fluid administration in those facilities, but we got there. It took some incredible nursing with the aged care facility nurses, syringing fluids into people's mouths to encourage them to keep hydrated. Yeah, really, really important that nursing care that was provided to have, you know, most of the residents actually have good outcomes from this. One of the learning that we had was, you know, the agency nurses coming in didn't know these patients, and basic things like who needed to be on thickened fluids and soft foods. It probably led to aspiration for one of the residents because there hadn't been awareness that in fact they were supposed to be on thickened fluids rather than just normal thin fluids. And then palliative care considerations absolutely came into play for a number of these residents. And what I might do is hand over to Nerida at this point in time because she'll highlight some of the important things in palliative care of COVID positive patients.
Oh, thanks, Ai-Vee. Thanks for having me today. My experience with the outbreak in the aged care facilities in Dubbo was at the start quite challenging, and there was quite a logistics going on at the start, communication being a big issue with aged care staff. But we, as you said, got around that. The hardest thing was, I found from a palliative care point of view, was that the staff who were familiar to these patients and familiar to myself were no longer working at the facility due to illness or other reasons. So there were a lot of difficulties with the staff that I had done extensive education with, who no longer knew, the pathways and guidelines that we had already had in place for COVID positive patients. So that was a bit of a challenge. I suppose the biggest thing is what I had always said to the aged care facilities is to make sure that your advanced care directives for every patient are, kind of in place and conversations have been had. And unfortunately, this when it came to the crunch, unfortunately, that a lot of the advanced care planning had not been put in place. So unfortunately, there were GPs who were having very frank conversations when these patients were really quite acutely unwell, when we could have had a little bit more preparedness for advanced care planning. And some of these patients were multiple comorbidities, some with severe dementia that should have had these things in place already. So suppose from a palliative care point of view is we want to make sure that early conversations are had, when there is a diagnosis of COVID. So goals of care are ready, all organised, and a clear plan is in place. And I suppose so the family are prepared for worst case scenario, which, in our cases unfolded with, a third or quarter of our patients. How palliative care I felt is that I worked with the GPs quite closely in having frank conversations with families, mainly about what the patient is likely to be experiencing and what medications would be using to help manage their symptoms, to keep them comfortable, and explaining, the medications in depth and end-of-life symptoms, and making sure that they felt supported, knowing that, there's extra support there for them. And it also helps me when their loved one does pass away. We are then involved in the bereavement process as well. So it's not only, because a lot of these families never actually got to see their loved one in their dying days, or months even, because of the lockdowns. So it just helps us with the bereavement process as well. I suppose what I found, and a lot of the GPs found as well, is that the patients who were palliative or had palliative intent, that their symptoms were escalated quite quickly, and we were basically going from using oral medications to manage symptoms to then subcut medications within sometimes, a day, less than a day. And the medication that we were using were quite high doses of subcutaneous medications. The frequency was quite high, and it was quite intimidating for our aged care nurses to be using those sort of dosages. It did require a lot of prompting and a lot of support from not only the GPs, but from my behalf, reassuring them that the medication at this high dose is what that patient needed to give them comfort in in their end of life process. So I suppose from a palliative care point of view, if we're involved early, it also helps us not only provide support for the GP with medication management, but also for the staff at the aged care facilities, so they can feel reassured and because the high doses of medication that we are using, which is subcutaneous morphine, subcutaneous midazolam, subcutaneous hydromorphone, pending patient's condition, they're quite high doses, and we were escalating, going from just subcut breakthrough doses to syringe drivers, sometimes within less than 12 hours, because we had no choice, because the staff were so hesitant in giving medication that we just had to escalate it so quickly to syringe drivers, which for most of those patients was the better outcome anyway. I suppose that the main thing is that we do have guidelines out there on how to manage end-of-life COVID patients, and I think we might see if we can organise to get those guidelines recirculated, Ai-Vee, and there's oral medications on those guidelines and also subcutaneous medications. I personally found, from a palliative care point of view, that the subcutaneous medications, having those crisis medications available to the patient if they weren't for transfer to hospital, and that palliative measures were a consideration, having them there charted, ready to go, was in the best interest of the patient, because it was then we could say to the staff, start using your subcut morphine, and we're not waiting for stock to arrive from the pharmacy. We're not waiting for the orders to be charted. It's there. It's just about initiating it with the RAP staff. Now, each individual area throughout this district will be different. So in Dubbo, we're very lucky. We have 2 palliative care nurses specifically for the aged care facilities in Dubbo. We are slowly starting to take on some of the smaller aged care facilities around Dubbo, so Wellington, Maranatha, and Timbabongi and Narromine. In places like Mudgee, there is a palliative care team there that have a different relationship with their aged care facilities, but if there is an outbreak, we'll certainly all work together to try and work on the model that we had here in Dubbo, because I felt that it worked really well, and the relationship that we have with our GPs here in Dubbo, it worked seamlessly, I thought.
Thank you for that rundown, Nerida, around the palliative care efforts, and I'll just echo that. A couple of the patients I looked after, when we normally start an opioid naive patient on 2.5 or 5 milligrams of morphine, and closer to 2.5 or even 1 milligram when the elderly and frail. These people were very much needing 5 milligrams, 10 milligrams at a hit each time to settle down the breathing difficulties. Absolutely fitted in with Louis Christie's write-up about COVID palliative care way back at the beginning of the pandemic, but that fitted in with all the overseas experience with palliating COVID patients. So I think I wrote up the biggest doses of syringe driver medications that I've ever written, and that's me having worked in Lord's Hospital as well in days gone past. But I think, really peaceful outcome for those patients who needed that care. Alex and Ian, I see your hands are up. Were they from before, or were they new questions that you had?
No, I'm fine.
Thanks, Ian. And I'll just go through, I'm sorry, I missed those questions that were in the chat. So I'll just go back to the Alex Hoyle's question about weekend care for COVID patients in general practice. That's a really good question. I think that's certainly one of the concerns from the local health districts in terms of, how will GP care look like on the weekends and during the after hours period. And my response to that is that I guess for each individual GP and GP practice, whether you utilise your existing after hours systems or you put in specific models of care for these patients, like, I guess a lot of us do for our PAL care patients at the moment. If numbers get large, I guess that's going to be a different story, and it's going to be have to be one of those things, like as Mel describes, do what you can that is good for now, but you may well have to change things down the track. It's certainly worthwhile a conversation at your individual practices as to how you would like that to look for your teams. Gary, that question around payments for involvement, I know there's been big advocacy at the Department of Health level around trying to get payments that are either practice nurse payments or block payments for care of COVID patients. I'm not quite sure where that is at the moment, Sonia, unless you've got further information.
We should know something very soon, and as soon as we get the go-ahead from the department, I'll happily share it with everybody. But it's looking promising at the moment that there should be some money to pay practices, hopefully block funding.
Terrific.
So yeah.
Okay, thanks. And we are just a few minutes over time already, but were there any final questions in relation to aged care facility or wider COVID care in the community at this point in time? I'll take silence that the answers have been given. But I just wanted to say a final thank you. And I don't think anyone realises or acknowledges all the incredible work that GPs have been doing across the state, but I think especially in Western New South Wales, testing, vaccination advice galore, jabbing, whilst trying to continue our usual services to look after our communities. We've had so many people run into troubles, emotional health wise during lockdown and all the changes that are happening during the pandemic period. We're there for them. Navigating exposure risk, having staff furloughed, adapting, and basically being community champions. But, I want to be able to say to, Western New South Wales GPs, you're just awesome. Keep doing the great job that you're doing. The next phase is onto us in the next little while with endemic COVID. It'll be yet another example of needing to adapt. I think one of the really beautiful things about Western New South Wales is that we've got each other to work with and help each other out. And so just as Mel said, anybody reach out at any time. And I'm saying, to each other's practices, reach out at any time as well. Myself, in relation to, I'm more than happy to be emailed. My phone is often not so great, but definitely reach out by email if you're wanting to get onto me and ask things, or if I can be of help in any way. And thank you so very much, everybody, for spending an hour and a half on a Thursday evening to talk more COVID. There'll be more COVID things coming in the not too distant future. Keep safe and keep well, everyone. Have a good night. Bye.
Thank you so much, Ai-Vee. Thank you, everyone.